how there has been constant discussion on how we as urologists and surgeons have been limiting ourselves to just being part of the anastomosis, either being a vascular or a ureteric anastomosis. There are surgeons who do only the ureteric anastomosis and there are urologists who do only the ureteric anastomosis, and the vascular surgeons do the vascular anastomosis. So everybody has decided for their own convenience, but as history goes, a transplant surgeon or a transplant physician should be well aware of in and around of the transplant science and the allied branches around it. uh, Today, the topic for us is, can a surgeon be on the driving seat for the transplant program? Can a surgeon manage the transplant patient in toto? We have as speaker somebody we all know, and I do personally very well, and I have learned a lot from Priyadarshi sir. So, welcome Priyadarshi Ranjan sir. Sir is a renowned urologist, and let me assure everybody in the audience that I am very in awe of sir, of how he now manages all his transplant patients himself. And let me tell the audience that all his patients refer him ESRD patients for transplant, because that is the result that he gives to them. This is a first-hand information that I am sharing with the audience, sir, with due permission of yours. But the idea of this webinar is, if you can please share with the urology and the transplant surgeons that how you have inculcated this practice, sir, and how you have developed yourself, gained this knowledge, had this confidence, having a surgical background, surgical training all throughout MCH and later, and now being able to manage the entire medical part of the transplantation as well. It's not easy. We all understand. We all have our fears. We all have our lacunae in knowledge. But I am sure that, sir, you have overcome these, and we request you to please present on how you've been able to do this, so that young generation like ours can learn and maybe inculcate for those who can. Sir, welcome to the webinar, sir.
Thank you, Akshay, and thank you so much for that kind introduction. And I would really like to thank all the academic council members of the ISOT for inviting me to share my experience. Although there are so many other senior people in the country who are successfully running the programs, but I'm glad that this opportunity has come to me, and I'll just try to share my experience over the past 20 years of program. So thank you everyone, and thank you, Akshay. So
Sir, before you start, sir, if I can just introduce our chairpersons for today, sir. So I let me introduce Dr. Rahul Yadav, sir. Sir, very good evening and welcome to this webinar. And let me tell the audience again that here is another man who for Rahul Yadav, sir, I know very personally, because I've been part of many academic platforms where I have had this opportunity to learn and interact with sir a lot. So, sir, sir's journey I know personally, but sir, after Priyadarshini's sir's talk, sir, I would like you to please tell the world how you have trained yourself. And I know the hard work that you've put in to learn the nephrological aspects, the dialysis aspects, the immunology, the pathology, everything around the surgical aspect, apart from the surgical aspect, how you've trained yourself, sir. If you can please share your journey. Um, uh, and welcome again to this webinar, sir.
Thank you. Thank you so much.
Right. And we all know Dr. Anant Kumar, sir. He is the doyen of the transplant world. We all know that sir is one of the fatherly figures of the transplant world, who has been managing his patients right from admission till discharge and follow up. everything. Sir would be joining soon. Sir is stuck in some clinical work. Sir would be joining soon. So, Ranjan sir, the stage is yours. You can start with your presentation. Mr. Himanshu, you
Thank you.
would be sharing sir's slides. And sir, if you can guide Mr. Himanshu through the slides, sir.
Yeah. Please. So, thank you, Akshay. And Anant Kumar sir is actually the forefather for all of us. Whether it is Rahul, whether it is me, we have the DNA of sir. So it's great that he'll soon be joining. And the story begins. My actual story begins from SGPGI because me and Narayan Prasad, the nephrologist there, we used to stay in the same building. So in the morning tea, we used to take the transplant ICU round, and all the discussion used to happen at that point only. So the bottom line is we should have a very good nephrologist friend who is continuously infusing with you knowledge and telling you where to get yourself packed up. So coming again, majority of my knowledge, in fact, when I came into practice for the first 5, 10 years, for every little problem, I used to rush to Narayan Prasad. I used to give him a call, and he was always very calm and smoothly telling me what to do. And slowly over the years, with CMEs, trainings, experiences, a lot of things you gather yourself. And if you're in a corporate setup, you learn so many things yourself that how you're going to survive in that setup. With that, coming to the today's topic, I was very excited to see the topic which you gave me, surgeon on the driving seat. So let me just show you how does a surgeon drive. So can we have the scroll down, please, Himanshu? So driving seat looks like this. The car, I'm sure everyone would like to drive such a beautiful car. But can you see the driver? If a car is driving, you can't see the driver. So to see the driver, actually a transplant program, just go down, please. We have to drive the car like this. Actually, we don't try, at least I did not try to drive. I learned to push. So transplant is a huge program which you have to push, and for pushing you have to come out of the car, and you have to be involved in each and every step. You have to learn to survive over events. There'll be several events happening during a surgeon's transplant journey, both medical, non-medical, legal. There are all sorts of problems which keep on happening, and ultimately you realize all the onus is yours. So surgeon is the one who is facing the music and facing the heat. So he has to be abreast and familiar with most of the things which are going to affect his surgery as well as his program as well as his career and his life too. So, for a transplant program, take responsibility for everything, whether it is your or not, whether it has gone infection, whether the immunosuppression has gone wrong, whether the OT staff while shifting has pulled out the catheter or the drain, whether the anesthesiologist did something, or whatever it is, take the blame yourself, take the responsibility. That is the first step for being a good surgeon. Next slide, please. So let us understand the mechanics in transplantation. The mechanics are that there are three people who are the stakeholders, key stakeholders: the surgeon, the nephrologist, and third person, which we often ignore, is the manager in the hospital in which we are working, who is the direct representative of the owner. And all three of us are the ones who are going to have a benefit or bad effect of this entire program. Next slide, please. So we have to understand the psyche of all these three people. The surgeon in the initial years has a psyche to protect his own reputation. When we are doing the surgery, as surgeons, our focus is that मेरा surgery ठीक हो जाए, मेरा anastomosis ठीक हो जाए, donor में कोई problem ना हो. So this is the psyche with which a surgeon goes inside the theater. The nephrologist also, because he is also a doctor, he has also an indirect reputation attached to the success of that transplant. The third person is the manager whose primary aim is, despite the program being running, the reputation, everything, the institution should make profit, and the EBITDA, good EBITDA should come out of that transplant. Next slide, please. आप ऊपर चले गए, नीचे जाना है. Next slide. So first 5 years in a new transplant surgeon's career, one should master the technique, because mastering the technique is very important. You have to, because we have been urologists, we are not trained in vascular surgery. So first step is how to handle the vessel. You should know which vessel is to be handled by which instrument, what kind of forceps to use for the vein, what kind of forceps to use for the artery, what kind of scissors you should have, what kind of loop, all the paraphernalia, as well as the actual surgical technique. Every transplant patient is different. Every patient comes with a lot of variations, but if you learn the basic principles, you are sorted. Technique wise, everybody is sorted. Once you know the basics, whether it is left side, whether it is right side, whether it is second transplant, third transplant, whether it is a frozen artery or a frozen vein, whether it is a atherosclerosed artery, you can tide over almost each and every situation if your basics are right. And the basic is that you have to give a good flow to the kidney. You have to give a good flow out of the kidney, and a good uh, pass passage to the urine. So for first 5 years, it takes a couple of maybe hundreds of transplants to master that technique and gain that confidence when you can start thinking beyond the technique. So the first aim is one has to master the technique for the first 5 years, and then as his journey progresses, then venture into other things. Next slide, please. So first formula is, if you are not visible in the program, you are invisible. That means everybody in the hospital should know that this person is going to do the transplant. So you have to be stay visible, and the best way to stay visible, as you can see in the picture, you have to come out of the car and push that car so that everybody sees that you are making efforts. Be involved on the road rather than the car itself. You have to come out of the car. You don't just have to drive, you have to reach a destination. Always imagine there are so many stakeholders, so many people involved in a transplant program. You have to reach a destination that your patient should emerge healthy and get discharged from the hospital. Next slide. So understand, you should be visible to the nephrologist. That means you should always have an active discussion with your nephrologist. Whosoever is giving you the patient, or whosoever is the treating nephrologist, or whosoever is going to help you should always involve him with an active discussion. Always be visible to the patient as well as the family. In fact, the donor as well. Most of the times we neglect the donor, we don't meet the donor. So be involved with the donor, understand the psych, under what circumstances is he or she donating, what is the family background of the donor. Try to know their story. You should be interactive with your pathologist, and this pathologist may not be from your same hospital. You have to find out who is the best person to interpret your biopsy results. See, once you know the clear cut diagnosis, it is very easy. Whether once there is some graft dysfunction, either it is rejection, or it is ATN, or it is drug toxicity. So, but you need a good pathologist who should tell you that, boss, this is this, and you need to this. Whether you need to stop the immunosuppression, whether you need to enhance the immunosuppression, whether you need to, whatever, decrease the dose. So, firstly, you need a very, very good pathologist, and over the years, by discussing with the pathologist, you know that what is tubulitis. Learn about, see how does tubulitis look like. You see how does glomerulitis looks like. So you should be able to make a diagnosis of rejection versus non-rejection by yourself. But still, idea is to have to be in touch with a very good pathologist, and whenever the biopsy report comes, always discuss and go back and study what kind of features were present and why has he labeled this. Next, blood bank. Again, blood bank people, you also need to be very well connected, because most of the times you might need to get a plasmapheresis done, or you might to get to calculate the titers in case of ABO compatible transplant. Go and see how a leukoreduced blood is being collected. Go and see which kind of blood is transfused when some mishap happens. Just see what kind of blood products we use for ABO incompatible transplantation. So all these things will be taught to you by a good blood bank or a transfusion specialist. Similarly, immunologist, you should be aware of CDC cross match. You should be aware of various types of cross match, and how do we interpret the results of these cross match. Down there are modern techniques such as ELISA, virtual cross match. So we should be knowing all these tests, and these are very, very simple tests. And once you start interpreting these tests yourself, you will know that which way to go for. Again, radiologist, being visible to the radiologist is again very important. Whenever the CT angio of the donor comes, if you feel it is not suiting the way you want it, you must go there, talk to the technician, radiologist, again do a 3D reconstruction to actually know what is the angle of the artery which is arising, what is the lie of the vein, what is the number of the arteries, how is the artery branching, what is the anatomy of the kidney. Many times a small arteries are rising. So all these things you will be able to know once you are interacting with the radiologist in the radiology suite on the console. So when he's doing the reconstruction, you can tell him that, boss, this is the way I want it. Sometimes the kidney is anomalous, there is some congenital anomaly. So these things are very important. One important thing which a radiologist will teach you is how to do a Doppler of the kidney, which I think all surgeons, transplant surgeons, should learn how to. It's very easy. In fact, it is one easier than the normal KUB ultrasound, because the kidney is very superficial, and you can easily, at least one should be make out, one should be able to make out whether the kidney is perfused or not first, and then how is the artery, which segments are being perfused, whether the entire pole is being perfused or not, or is there any hydronephrosis. So some basic things you should be able to make out yourself before the radiologist arrives. Then again, for doing a biopsy, I always do all my biopsies myself. So once you are regularly doing biopsies, then you again have an idea of what kind of anatomy a transplant kidney looks like. Whenever there is an obstruction, whenever there is some lymphocele, you can do the aspiration. If there is a urine leak or an obstruction, you can easily put a PCN or do an antegrade stenting. So all these things are very, very important. Once, and these things will come only when you are in active discussion with a good radiologist, and the phlebotomist also, because the HLA sample needs to be very, very carefully and video recorded. When it is being withdrawn, it has to be video recorded, so that all the legal responsibilities between the donor and the recipient are very, very clear during the sampling. So all these people you must be directly involved with talking to, so that they have an idea that this is the person who is a key stakeholder. Next slide, please. Identify your friends, hospital administrator, nephrologist, call center staff. These people are also very important. Sometimes the other people in the hospital don't know if a call is coming for a transplant, whom to contact. So they also need to be taught, because call center staff is constantly changing. Transplant coordinator, be very, very closely working with your transplant coordinator. Again, dialysis staff is one of the most important persons with whom we should be in touch with, because number one, he takes care of your patient's dialysis beforehand, and he might be knowing the things which not even may your nephrologist might not even be knowing, your anesthesiologist may not be knowing. Only the patient knows, or the dialysis technician knows, such as how many hours of dialysis does this patient need, how often is he being dialyzed, what is the amount of fluid which is being removed, how is his situation during the dialysis. During the dialysis means some patients may develop hypotension, some patients might develop arrhythmias. So the adequacy of dialysis is very, very important before we take up a patient for a transplant, which as surgeons most of us miss. it is very, very important to be involved in the pre-transplant course of the patient. So once you know the hemodynamics of the patient beforehand, once you take up that patient in the OT, your goals are very clear. How much fluid do I have to give when I'm releasing the clamps? What is the patient's tolerance? So all these things are very, very effectively communicated with a dialysis staff if you know who is doing your patient's dialysis. Again, the radiologist is very important. Media, I'll come later on. Pathologist, blood bank, anesthesiologist. Again, anesthesiologist is also very, very important person in your program. Out of the 5 or 3 or 10 available anesthesiologists, you will be able to know in some time who is the best possible anesthesiologist for your cases, who is the best possible anesthesiologist when the patient has a ejection fraction of 25%, who is the anesthesiologist when the patient is a pediatric patient, who is the anesthesiologist when you are going to do a ABO incompatible transplant. So every anesthesiologist has a peculiar niche. So in every hospital, there are certain anesthesiologists who specialize in transplant anesthesia. So your rapport with the anesthesiologist should be so comfortable and so communicative that the moment you lift up your head, your anesthesiologist knows what you want. Again, the OT staff and ICU staff need to be in the same lines as well. Next slide, please. So the areas to work are, I've divided it into primordial. That means the surgeon should be involved when the hospital is getting the license, right from that stage. Primary means pre-surgical, secondary means during the OT, tertiary means follow-up, and quaternary is something how you build up the entire program. So next,
हो एक वेबिनार सुरू आहे तुला काही काम आहे का
next slide, please.
बरं बरं
Next slide, please.
नाही नाही पंखाही नको एसी नको
So again, as you grow in your career, you should make a very clear-cut policy of admission in the hospital. Which patient is going to get admitted under whose name? Most of the hospitals, many a times, since the nephrologists are the primary handlers of the patient, most patients get admitted under the nephrologist. So there should be a very clear cut policy in the hospital because it is going to affect your future. So you should know that which patient is going to admit directly under the surgeon, which patient is going to be admitted under the nephrologist and the surgeon together, and which patient is going to be admitted primarily under the surgeon with a nephrologist as the co-admitting doctor. These things are very, very fine and very important because they have legal consequences as well, apart from financial consequences. Next slide, please. The primordial involvement consists of, we should all read the act, study the act thoroughly. 1994 act, the amendments which were made in 2008, the amendments which were made in 2014, as well as your state's policy, which kind of what amendment your state has actually adapted. So all these things should be very clear. You should understand the structure of the government machinery. Since transplant is a process where there's a lot of interaction and liaising with the government which is involved. So you should understand how the government machinery has been structured to control the transplant program, as well as learn about the state hierarchy. Who is an appropriate authority, who is the highest appropriate authority, appellate authority, authorization committee, and you should be aware of powers vested in different kinds of these government authorities. You should know who is the troubleshooting authority, when to approach the court, or when the patient gets a permission from the court. So all these things are very important to know beforehand. One thing more which we often keep discussing in the group, we, at least I, collect all the copies of the high court judgments whichever comes for the transplant, whether it is for the swap first degree. Recently there was a judgment for swap transplant for allowing second degree relatives also. So multiple there have been many high court orders for practice of the surgeon at more than one place or more than one center. There are orders about the NOC of the state. So different states, there are different kinds of high court orders which are there, which as surgeons we should have a copy of it. I always have all the orders in my file. And then you should be aware of the designated personnel at the government office. Suppose if the authorization committee is at a state level authorization committee, who are the key stakeholders, who are the key members of those committee, who is the representative of the DHS, who is the representative of the SDM, who is the representative of the social standing. So the component and the composition of these authorities is very important to know. You, at least in your own hospital, you should be able to assist the formation of the committees, who can be the members of the authorization committee, who are the members of the state level authorization committee, who could be the members of the brainstem death committee. So as a surgeon, you have to be involved in all these areas so that the entire program is growing in due course of time. Know the requirements. You should be clearly knowing the requirements as per the Human Organ Transplant Act, what infrastructure is needed, what kind of OT is needed, what kind of blood bank is needed, what kind of personnel requirement, degrees, qualification, experiences are needed, and which services can be outsourced, such as HLA testing, what kind of documentation is needed for outsourcing these departments. So all these things also contribute to your effective understanding of the entire transplant machinery. Next slide, please. Next slide, please. The next important thing is that one should have his own team which is developed. Make your own workup list. You, every surgeon should have a physician assistant who is a trained, either it could be a trained nurse or an MO, somebody who takes care of a lot of non-medical or pre-medical things for your patients, such as daily queries, how many phone calls you are receiving, how many calls have come to the hospital. At the end of the day, somebody can go to the call center and ask, was there any inquiry about the transplant or something like that. Or if you have a team of transplant coordinators like I have, so I, at the end of the day, I take up all the queries. How many calls did we receive, which patients are undergoing workup. You should have a daily updated list of workup. You should be able to know by the end of the day that there is any issue in the workup of this patient. Sometimes some patient falls ill, sometimes the patient's finances are finished, sometimes the police verification is a problem, some patient becomes sick on dialysis. So once you are continuously looking at your list, you know which patient is going which way. Suppose once you know that this patient was admitted 2 months back with sepsis and fluid overload, you know that his dialysis is not going optimally. So all these things should be a daily routine. Then you should be able to have a good relationship with your ANS nursing superintendents, because they are the ones who take rounds of the ICUs and the entire hospital, and they can bring out the brain death data, or some patient who is brain dead, brainstem dead, which, who wishes to, whose family wishes to donate organs. So all these things you should be able to connect it. One more important thing which I've started doing is that I register all my patients in the Noto and create their own Noto IDs, whether they have a donor or not. Because now the cadaver disease program is growing up in the country, so many a times there are cadaver donors available. You get a call from the DGHS or the Roto that this organ is being offered to you and whether you would like to accept it or not. So if you don't have your patients registered, then you don't have an option. So make sure the patient, once the patient starts workup with you or is under your follow-up, make a Noto ID, ask your transplant coordinator or your physician assistant to make a Noto ID, and every patient's Noto ID must be displayed. So whenever there is an option, whenever you get a choice, you can always get a kidney from XYZ place. Then always keep regularly examining your patients. Examining your patients, keep looking at their AV accesses, keep looking. Some patient might have gangrene in the leg, some patient might have poor ejection fraction, some patient might be requiring ICU admission, some patient becomes unstable on dialysis. So all these things must be brought to your notice, so that you know, once you know the pre-op course, the operative and the post-operative course is very much predictable. Then non-medical help to patient. Always be very proactive in helping all the patients in the non-medical terms. Heal them before surgery. That's what I feel. For example, small things. A patient is coming from Odisha to Delhi or to Chandigarh. He is looking out for accommodation. Since we are residents, we know a lot of property dealers, we know a lot of accommodations which are available nearby. You can help him book an accommodation for 3 months. So these things, these helps these families and patients very much. देन कम्युनिकेटिंग विद द लॉयर्स, उनका नोटरी से कम्युनिकेशन कराना, एफिडेविट बनने में दिक्कत आ रही है, कोई लैंग्वेज गलत हो रहा है, कोई छोटा सा वर्ड गलत हो रहा है, हॉस्पिटल का नाम सही नहीं आ रहा है, जो लॉयर वहाँ बैठा है या जो एसडीएम वहाँ बैठा है वहाँ तक पहुँच नहीं पा रहा है कागज. सो हु आर द अप्रोप्रिएट अथॉरिटीज विद whom whose signatures are the must, what kind of affidavits are being made. Don't leave all these work to your transplant coordinator, because your position is different. As a surgeon, if I call up the police or I call up the even the office of the executive magistrate, they respond in a different way rather than the transplant coordinator calling up. So we should be connected with all these government offices as well. They are not necessarily the senior most people, but they are junior most clerks, they are supervisors who are very ready to help for us as doctors. So all these non-medical helps should be offered to these patients. Next slide, please. Next slide, please. Sign your own files. Once your transplant coordinator, your physician assistant makes your own file, you should know what kind of investigations are being done, what is form number 5, what is form number 21, whether all the prerequisites are in place. You can see the affidavits, you can sign the pictures, you should see the ITR of the donor and the recipient, bank statements, covering letter, HLA recording, and also get your name registered for the PCPNDT Act, because that will allow you to use the ultrasound. So all these things should be very, very clear before you are entering a program. Next slide, please. Then stick to basics. I always carry a stethoscope. So auscultate the chest. Whenever you see the patient before, during workup, always auscultate the chest. It will tell you whether he is in fluid overload, whether he has effusion or some kind of infection. Again, the assessment of these are all steps to optimize your patient towards the surgery. You should see what is the ejection fraction. Most of these patients are hypertensive, they have left ventricular hypertrophy. You should know what kind of cardiac functional reserve is there, because uremia itself causes cardiomyopathy, which is called as uremic cardiomyopathy. So these patients are in a state of suboptimal dialysis, so their heart gets depressed. So once you start them dialyzing optimally, their cardiac function recovers. So all these things you should be knowing, and you should know which patient is at a very high risk for undergoing coronary artery disease or angina, unstable angina, or a myocardial infarction. So at least one of the stress tests, such as TMT or a stress echo or a stress thallium, should be done prior to your cardiological workup and before referring him to a cardiologist. You should be aware of what kind of medications are used in CKD, and this is a very, very bare minimum, because especially anti-hyperkalemic drugs, to neutralize the pH of the blood, for hypertension, for acidity, for hyperphosphatemia, for calcium replacement, anemia, everything. You should be aware of what are the basics of CKD medications, so that you must instruct your physician assistant that he or she should write down the drugs, and if there are any changes which need to be done, you can also do that. This enhances your coordination with the patient and your warmth with the patient. Always examine the pulses. If you feel that there is some problem, get a Doppler done, urological issues, your strategy to manage the anemia. If somebody's hemoglobin is 5, how are you going to correct his anemia before the surgery? What is the weight of the patient? Whether you need to transfuse blood before the surgery? If yes, what kind of circumstances will you transfuse? Which kind of blood product will you use? Which kind of immunosuppression will you start while giving the blood? How many days before can you give the blood? and if you give the blood, when you have to repeat the cross match. So they are very simple logistics which we understand while we are in touch with the patient regularly. We assess the frailty of the patient, his protein, energy, malnutrition, volume optimization. All these things are possible once you are in touch in pre-op with the patient. Next slide, please. So optimize before you are actually going to do the surgery so as to have a very swift course during the surgery. Patient should be adequately dialyzed. This is very, very important. Most patients who come from far off centers are not adequately dialyzed. They are suboptimally dialyzed. That is the reason they land up with a lot of complications during the anesthesia and during the surgery. Risk of rejection, you should assess how is the history of sensitization of the donor, whether a cross match has been positive at any point of time, whether he's for a first transplant, second transplant, retransplant. So all these things you must look into, must discuss with the nephrologist what is the tentative plan of immunosuppression, what is the tentative dose of ATG or basiliximab is being planned, how is the maintenance immunosuppression being planned. So all these things, you should be involved in decision making. You should be involved with the anesthesiologist for the plan of anesthesia. What kind of lines do you need, whether you need an arterial line specifically or not, because it tells you a lot of other things also. Then management of anemia, CKD drugs, arrangement of leukoreduced PRCs, albumin, ATG, all these things should be under your knowledge before the patient is being taken up for the OT. Next slide, please. Next slide. So as we have good accessories for our cars, we should have good accessories for ourselves. A good headlamp is a must. कई बार ओटी की लाइट इधर होती है, कभी टेढ़ी जा रही होती है, कभी जल नहीं रही होती है, कभी उसमें हैंडल नहीं होता है. सो यू कीप स्ट्रगलिंग. नोबडी गेट्स अ परफेक्ट ओटी. Always have invest in a good quality headlight, a good quality vascular forceps, one for the artery and one for the vein, at least 8 to 9 inches in length, so that you can easily operate obese patients. Take the counterbalancing forceps, beautiful forceps. आप 4 transplant भी करो तो आपका हाथ थकेगा नहीं. Good quality needle holder, something which is going to hold your 70 very well, which is going to hold your 60 very well. You should know which needle holder to use when. Try to learn what is the best direction of movement for your wrist. God has given us 2 hands. These movements one needs to master. Which kind of movement works best for you, where to take a backhand, where to take a front hand. All these things come with practice and by repeatedly doing the same thing. Invest in a good pot scissor. Invest in good quality clamps and bulldog clamps, vascular probes, retractors, and of course loops. So I think every surgeon should have a set of these 5 6 things for himself, whatever is his capacity to buy. Which are, there are so many companies, right from average to good to very good to excellent to superb. So you can buy your set of instruments as per your capacity. Next slide, please. So in the OT, always make it a habit that the surgeon enters the OT before the induction. I have followed this rigorously for the past 20 years. I always meet the patient beforehand, before he gets induced. There is a lot of anxiety. There's a lot of the patient, the psyche of the patient and the donor is entirely different. But once they meet you, they see you, then they are good to go. So I always do it, and I will always encourage everybody to go and meet the patient personally. Once the patient is being anesthetized and once he is extubated, you should be there. So it builds a different kind of rapport with the patient. That patient is never going to forget you in his life. Then always discuss with the anesthesiologist what is the plan. Just see, he's the same anesthesiologist who has done the PAC. Is he the same who is giving the anesthesia? Does he know the issues? Does he know the cardiac status of the patient? Does he knows the dialysis status of the patient? Does he know how much fluid has been removed prior coming to the OT? Whether the patient is being dialyzed or not, whether the patient is anuric or he is oliguric or he is producing normal urine. All these things should be between you and the anesthesiologist, so that you can plan your volume optimization even before the patient gets induced. Tell your requirements to the anesthesiologist, communicate freely about what kind of volume would you want to load him, which kind of drugs, and what is the timing, what is your anastomosis time, and by what time how much volume you need, which drug should be given by, for example, ATG should not be given very rapidly, otherwise it causes hypotension, many a times it causes arrhythmia also. So you should know which drug has to be given by what speed. Then OT technicians, whether the same technician is present who is always there in your cases, how to make the position of the recipient, where to fix the catheter, how to fill the bladder, all these things are done by the OT technicians. So they also help a lot. Your own staff, your assistants, are they familiar, are they with the ones who are same? I always insist that we train 3-4 nursing staff or OT assistants, OT technicians, or maybe your own physician assistants to regularly handle the same position, so that over the time they become accustomed to. And always meet the family also before and after the surgery. And once you are taking post-op rounds, even though the patient is well, then also you should meet the family, so that your rapport with the family is always good. Next slide, please. So in the OT, like at my most of the times I organize things and I delegate responsibilities. I go only and only for the main steps. You have to disseminate your headache to everybody else. You have to find out who is the best person to do what, and then delegate that person. Delegate who will make the slush, who will put the catheter in the donor and the recipient, so that if there is some problem, you must immediately know who will do the donor. Is your junior going to start the donor? Is your nurse going to start the donor? Who will close? Who will be on the floor for trouble shooting? कभी हार्मोनिक गड़बड़ हो गया, कई बार आपने हिमोलॉक लगाया तो गड़बड़ हो गया. और हमेशा in the mind always think of that one person who will rescue you when you are putting the clip on the renal artery and you see a tear from the aorta. Most of us might have experienced, who all of us who do laparoscopic donor nephrectomy, this is a very, very dreaded complication, and you must, although you can do the entire procedure yourself, but you must know who is going to be the standby person who comes to your rescue the day you tear the aorta. So who will be on the bench, who will prepare the bed, who will close, who will carry post-op orders, who will check the equipment, all these things need to be decided beforehand. Next slide, please. So post transplant, initially as surgeons you can offer free OPD, so that at least the patients are in touch with you. They come and show the nephrologist, but you also see them, so that you have an idea what kind of immunosuppression they are undertaking, what kind of problems they are having. Always listen very carefully to the problems of the patients and their common issues. Remove the stent yourself, at least in initial years. Don't designate your resident or maybe some OT staff to remove the stents. Look at the dressing yourself. Look at what kind of diet he's following in the first 3 months, 6 months. Some patient might be obese, some patient might be diabetic. You should be able to make the corrections in the diet yourself. Incorporate best screening protocols in your follow-up, and always don't forget to celebrate with your team. Always, whenever there is a small milestones, maybe first 25 transplants or 100th transplant or 1,000th transplant or a robotic transplant or 20 ABO incompatible, always find a moment to celebrate with your team, so that there is cohesiveness amongst all the members of the team. Next slide, please. Screening protocols. Try to attend as many trainings as possible. Go and attend the American Transplant Congress. Go and attend the EDTA. Go and attend the European Congress. Go and be a member of the TTS. Be a member of the Australian Society and New Zealand Society, because once you attend these congresses, especially in the US, there are so many programs, Arthur Mata's, Robert Montgomery, which are surgeon-led programs. Whenever you go get an opportunity, once you go into the conference, you always get an opportunity to visit their program and see how these surgeons are running their programs. It's very, very important to develop your own confidence. Implement world's best immunosuppression protocols, whatever is the best for your patient and the kind of population you are catering to. Implement that. Learn from your surgical complications. After a period of say 5-10 years, surgical complications are ironed out, and most of the cases you will not see surgical complications. You should be able to master over the procedures of Doppler, ultrasound, biopsies, try and be actively involved, or else manage yourself the rejections, the kind of immunosuppression which is being given to the patient, and always assess the need of the net immunosuppression for the patient. What kind of TAC level is suitable for him? Somebody will have a toxicity at a level of 3, somebody will be doing very well at a level of 20. So you have to see what is the inter and intra patient variation of the tacrolimus, which lab you are choosing, what kind of sample is being given. All these things are very important. And yes, which drug should be taken with food, which drug should be taken empty stomach. All these things make a lot of difference. You know what kind of infections, prophylactic drugs we are using, the screening for coronary artery disease, tumor, hyperglycemia, no DAT, metabolic bone diseases, sarcopenia, pregnancy clinic, proteinuria clinic. So slowly and slowly, as you mature in your program, you know these are the protocols which need to be implemented. Next slide, please. So since we are driving a car, we should know what can puncture the car. So one most important thing is financial non-optimization of the patient. Most of the times when a patient comes to you, say somebody is coming to you from Bihar or from UP, he has a fixed amount of budget. He comes with a budget of 7 lakhs, 8 lakhs in which he has to stay. He has to get his dialysis done in between. He has to run for errands. He has to arrange for his household also. And if he has to go back again to his parent state, he has to spend money from that only. So always in the first meeting, try to assess what is the budget of the patient and how much financially paralyzed is the patient. Is he getting a government grant? If he is, try to facilitate it. Is the patient arranging or borrowing funds from somewhere? Try to facilitate. So all these things you should know: which patient is cash paying, which patient is insurance paying, which patient needs your more attention. Once you know his finances, you will work that way. You आपको ये मालूम है कि इस पेशेंट का बजट 5 लाख रुपए का ही है, तो मुझे इसका ट्रांसप्लांट 10 दिन में कर देना है, no matter how. You give your instructions to the team that this patient should be on the OT list on this day and start working like that. उसकी authorization committee इस डेट को होनी चाहिए, उसके एफिडेविट्स इस तारीख को बन जाने चाहिए, उसकी पुलिस वेरिफिकेशन इस तारीख को आनी चाहिए. So go work retrograde, so that you are able to mature that patient on time and he survives the transplant both financially and medically. Don't ignore the government laws. Be very, very careful with the act. Be involved with the pre-op preparation with the patient. Have good communication with the anesthesiologist, especially if the anesthesiologist is a new anesthesiologist. OT staff, sometimes the OT staffs are very careless while shifting the patient. They might pull the catheter, somebody might pull the drain. So these things keep happening in every program. You just be very, very careful for those things. Next slide, please. Then as you mature in your program, try to be away from the routine noise from the transplant. Think of bigger things, such as organizing a transplant game. Call your patients for games, small activities, cricket game, hockey game, football. Book a stadium in your city. Try to be involved with your patients. Try to encourage them for a good, healthy lifestyle. Try to encourage them for world transplant games. Do CMEs not only with your OT staff but the doctors around. Once you do something good, put it in the media. Let people know that you are doing such kind of work. You are doing an ABO compatible transplant or a robotic transplant. Whatever is the new technology or a technique or an achievement, try to disseminate inside the hospital as well as the outside. ABO incompatible transplants, plan for them. Plan for swaps. Paired kidney exchanges is a big need of the hour. So we make a separate list for a swap transplant program. Try to match the O donors to increase the pool of the swap transplant. So all these things you can only do once you have your mind putting in when you're sitting alone in your chamber. Try to develop deceased transplant program, DNB trainees, as well as transplant coordinators training programs. Next slide, please. So just remember, every patient is a chain. Even आज भी जो patient 15 साल पहले मैंने transplant किया था, वो नया patient ला के room में बिठा जाता है. So this happens only when you are actively involved in the care of your patient. So every patient is a chain, and believe me, each patient, at least one transplant patient brings 10 new transplant patients to you. So it is very, very important to take care of that one patient completely rather than taking care of everything else. So, with that, I would like to close my experience. And if there are any discussions or any questions, I would be happy to contribute. I hope I didn't bore you, Akshay.
Sir, thank you so much. I mean, clearly, this was a presentation out of experience, and this was the journey that it was very well visible on your slide, sir. Each word, I think, has come from hardcore hard work. That each point which you have jot down, sir, it is definitely come from uh, years of hard work and pure experience, sir. I mean, thank you so much, sir. Rahul,
Thank
sir,
you.
your comments, sir, please.
Yeah, Dr. Priyadarshini, excellent demonstration of all the logistics and everything. I mean, truly a great presentation. I mean,
Thank you.
and I also learned a lot. I mean, so apart from this, what I want to add is, I mean, despite having a nephrology friend and learning from nephrologist, that is to be doable and that should be done. I mean, this is the way to go forward. Apart from this, what I wanted to add is there are some programs from some dedicated programs which one can learn actually, because all these things everyone tries to do it, but at the end of the day you will feel the lacuna where there is a deficiency in the knowledge. You are not able to correlate things appropriately. So basically, there are so many few dedicated fellowships are available. I mean, Akshay, if I can share my slide, I mean, share my screen. I just have two,
Please.
three. If we have time, I mean, if we have time.
Sir, please go ahead. Very valuable information, sir. Please go ahead, sir.
So, is my screen visible? Yes.
Yeah,
Yes, yes, very much, sir. You can make it slideshow, sir.
So, okay. So the thing is that I am trained from Dr. Anand Kumar. So हम उनको गुरु बोलते हैं. I mean, because he does everything on himself, and there is always a zeal to do transplant from beginning to the end. But all in all, the problems comes down regarding the knowledge, because we can't match the knowledge that our fellow nephrologists have. And obviously, something is going to come with the experience, but experience will take a hell lot of a time, maybe 20 years, maybe 25 years, maybe so many number of patients, which is not feasible in each and every scenario. So what I wanted to highlight here is there are few dedicated programs where we can actually learn all in all about transplant, right from nephrology even to urology. One of such fellowships I have done actually, and a fellowship in clinical transplantation which I have done. It is a basically practically a 2 years course, and there are got 6 modules in it. And the modules will round about 4 to 5 months. But all in all, such kind of a dedicated program will take around 2.5 to 3 years. And but the programs needs a hell lot of commitment. I mean, if I would tell, I mean, daily commitment of 2 hours for 2 years is very difficult for all of us. But yes, if we want to excel in something, if we want to learn something, and if we have some, I mean, interest, I mean, then we can definitely go about it. So if I'll just a brief snapshot, maybe I'll take another 5 minutes. I mean, if I'll see just 1 week of that module, I mean, if you see the week 2 of the module, there is a lecture, there are scenarios. These are clinical scenarios. These scenarios which has happened, I mean, to the chairpersons who have made this module. And there are few general clubs which you need to answer, you need to summarize, and after that there are the MCQ questions. This is just 1 week program. I mean, this is you are going to do every week for 10 weeks in 4 months, and practically lot of labor, lot of reading, and lot of practical knowledge. If I talk about just one scenario, this is just one scenario, and if you see, one has to answer all these questions. This is regarding each and everything. The module will cover right from immunology to advanced immunology to nephrology part to post-transplant care to long-term transplant care. And for answering this one question, one has to search a lot. One has to see the literature, then needs to answer all these questions, and that needs to be done. You need at least a 70% contribution to pass the module. And if I talk about a general club, this is the general club, which is not related to urology, not related to anything. But yes, this is a general club. I mean, bone and mineral disorder renal transplant patients. Nobody is aware of it. I was not aware of it, I mean, before. And once reading through this, you need to summarize it. There may be some questions regarding to this. So every week is a very intense week, which is you are going to do for another 2.5 to 3 years, which practically, honestly speaking, which covers entire of a transplant, a ESRD, and post-transplant care. And it also includes a long-term transplant care. Even it teaches you a pathology also. I know how to read the slides. I mean, I may not be that pro into reading the slides, but I can make out. I mean, what is happening? What kind of rejection is happening? Is there C4D positivity? Is something happening? Is a neutrophil there? I can able to read out slides because of all these things which has happened over a period of 2 weeks, 2 years, sorry. And these are kind of the MCQs. These are long MCQs. They are real scenarios which are being put in a labor which has been put by a 30 to 40 years of experience by some other people who made this module. And always there is an assignment. I have written a paper on a review article because after 4 months you give a they give an assignment to you. So I chose this assignment and I have to write a paper and I wrote a review article, basically a 6,000 review article, a post transplant malignancy which nobody knows. So apart from all these trainings, the important training is a dialysis training. I mean, you need to know kind of fistulas, how to make it, what problems can occur, what things you can do. So there are so many conferences available which are just focused for this. This is one dialysis access synergy which I used to attend in Singapore. I mean, this happened in Singapore, a 2 day conference just on the dialysis access. Nothing, right from beginning to end, including Doppler and everything. There are so many dialysis access symposium happening in the world. This is one other Hamburg. I mean, there are so many things happening. So in between, as Dr. Priyadarshini has rightly pointed out, that you need to go out to talk to people, to go to the conferences to actually learn. Because dialysis is something which is not in our training, I mean, practically speaking. So right from the access to managing to access problems, what can be done, sometimes a difficult fistula, what kind of vein, what kind of artery we should look at, where to make a fistula. There are so many things which can be learned out of this. So there are also some 15 days fellowships at Japan and Thailand. I mean, one can go and usually and can learn about fistulas and even the endovascular interventions also. That is all. So all in all, apart from these logistics, I mean, if somebody wants to learn regarding, obviously, whole about the transplants, so all logistics needs to be taken care. Apart from, there are some dedicated fellowships, dedicated trainings, dedicated conferences, which can really help. That is all from my side.
No, exactly, Rahul. In fact, I have also done Ahmed Alawa's module,
Yes,
so it is
yes,
very difficult to pass. So I'm sure it's a very, very good. Only thing is, it is very time taking, but he
yes.
has absolutely exhaustive knowledge. The kind of general clubs, in fact, all these screening protocols of malignancy, metabolic bone disease, I've implemented from that module only. So we need to continuously update ourselves and keep on meeting like-minded people who can give you a lot of energy and exchange of ideas, exchange of knowledge, which actually happens. A lot of learning happens in the conferences and meetings. We just learn one small little point and it changes our practice. So
Right, sir.
yes, absolutely
Sir,
agree with
one
Rahul.
one point which I think might motivate a lot of youngsters who are young in their practice. If you can just, each of you experienced guys, sir, if you can just tell at what point of your career, like after passing MCH and all your urology training, you came into practice, probably were a part of the transplant team. When exactly, after how many years into the transplant program of some hospital somewhere, you felt that, okay, I can manage my own program and let me develop this um, uh, uh, the entire ideology. You mentioned, sir, that Narayan Prasad, sir, who's a renowned nephrologist at SGPGI, for the audience, I'll mentioning again. Your discussions with Narayan Prasad, sir, gave you a lot of insight. And then probably you picked up these nuances yourself, got the knowledge probably took rounds with nephrologist, learned the intricacies of each and every aspect of the transplant science, be it immunology, pathology, rejection, biopsy, Doppler, everything around the transplant program. But at when exactly did you feel that no, I should take this up and I'll manage the entire patient walking in and the entire process of the transplant pre-op workup, and obviously the surgical part that you do. When was this, sir? Why I'm asking you this is, sir, this even Rahul, sir, I would need an answer from you as well, because if somebody is early in his practice, it's not too late to do that if somebody is really passionate about getting these things done. Sir, if you can please share your experience.
So
Ranjan, sir.
with me, the change happened in 2011 when I went to Professor Robert Montgomery at the Johns Hopkins. So if you see in the US, majority of transplant surgeons are running the programs. You name any surgeon, Arthur Matas, Robert Montgomery. Most of the surgeons are quite involved in the program. Idea is not to lead. Idea is not to have a name. Idea is to have a satisfaction. Idea is to give that patient a smile which he has been looking for. You only need that passion. It is not about controlling or driving the program. It is about creating an ecosystem where you feel comfortable. For example, if there are so many things which as a surgeon only you can tell, nobody else has experienced that. How was the kidney perfused? When you are very very clear that this kidney perfused very well and my surgical technique is very right, nothing can go wrong in the post op, you have that confidence of labeling it rejection. You know the color of the urine. By spending time with the patient, nobody can actually tell कि इतने time में कर लेना, but by just spending your nights in the ICU, you know what is this color of urine. ये थोड़ा सा dusky लग रहा है, ये थोड़ा सा concentrated लग रहा है, ये ATN वाला लग रहा है. So many things you just know by looking at the Eurobag. It is actually the time you spend in the ICU that makes you wiser. There is no time limit. But for me, the change actually happened when I was with Montgomery for around 2 weeks, and he was so kind with me. He used to take to me to each of his pathology rooms, immunology rooms, transplant meetings, OPDs, OTs. So that was the most fortunate period for me when I learned so many things from him. His team used to fly to get organs from outside. And similarly the live theaters were going on. So Doris Sajev was very much involved in paired kidney transplantation. So all these things, once you go out and visit a center which is a surgeon driven center, you learn so many things. And now the entire team of Johns Hopkins has shifted to NYU Langone Medical Center, and Montgomery is always he's a person who is very very keen to teach youngsters. And every surgeon who is planning to have a career in transplantation must visit Professor Robert Montgomery's center once, whenever it is possible, through an email, or maybe I keep on meeting him, I can arrange it. But then it is very important to visit a good center before you actually come down to your center and start taking the responsibilities yourself. For
Right, sir.
example, in Korea, if you see the ABO incompatible program, Dr. Anand Kumar's friend, uh, so all these people are actually running the programs, and it is not just to lead, it is just to see that the patient's outcome is good. Because most of the things you know, and after a certain while of experience, you know that these are the common problems which are going to happen. This looks like BK virus. So once you set up your own screening protocols, the patients automatically go under those protocols, and you are able to make out most of the things which can go wrong. Metabolic bone disease, so we have a protocol for a QCT or a DEXA scan. We have a protocol for intact PTH. We have a protocol for monitoring for malignancies. So all these things come with time, and you know what is suitable for your kind of population. For example, basal cell carcinoma we don't see here. What we see is NHL happening. So, what kind of malignancy workup you need to tailor to our subclass of patients? These things come with time, but yes, visiting a very good program is a must. Somewhere one must spend at least 15 days to a month to understand how these teams work to build up such beautiful programs.
Right, sir. Rahul, sir.
Once I moved out from Max, I mean, I trained under Dr. Anand Kumar. Once I moved out from Max, I feel practically handicapped when it comes to transplant, apart from the surgical part, apart from doing a transplant or just an initial workup of the donor in recipients. I always feel there is always a deficiency in the mind which was going on, that what should be done. I try to search a lot of programs. I try to contact so many people abroad, across. Maybe I can come over for a month or maybe 2 months and they can teach me most of the things. But usually these things doesn't work out most of the time. I mean, because all these things will add upon the basic knowledge you have. I mean, you can't build a basic knowledge and go to a limit where you should know each and everything. So some basic things one has to know. Then I fall upon this fellowship, and then obviously after joining this fellowship, there is no comeback. And practically speaking, for the last practically coming to almost 6, 7 years, close to 7 years, I mean, there is no look back, and practically treating patients on my own. And recently, I done a histoplasmosis. I mean, last 2 months back. I mean, a histoplasmosis which has not happened in the lung. He has got a cutaneous histoplasmosis, which is very, very, very rare. And just because of my knowledge, because I have done all these learnings and everything, and the guys practically, I mean, the lesions have gone out. Though I need to continue the antifungal till lifelong. But obviously, all this situation doesn't panic us. I mean, because there are so many things which keep on happening to the transplant patient. If you actually have a long-term follow-up, once you start doing transplant and transplant coming back, you may see a different class of complications 5 years, 6 years, or 7 years down the line. So all in all, I mean, the gradual learning from the patients, and obviously a basic framework in terms of joining and completing all these fellowships definitely help.
Right, sir. Uh, Thank you, Ranjan sir. Thank you, Adav sir. There is a comment from Nitin Negi. Sir, he is congratulating you on your excellent presentation, and he is asking if this he can have this link of the webinar. So, Dr. Negi, this webinar will be available on the ISOT YouTube platform. You can go log into the YouTube page of ISOT, and you'll find this presentation maybe after tomorrow. And rest assured, anybody who is passionate, like Ranjan sir said, it's all about passion and satisfaction and what you want to be known, or have that fire in you. If you are passionate about transplant, these things happen to you automatically. There is a process. Nothing happens overnight, is which is very very clear from these two gentlemen. You really have to work. You have a basic surgical training. You have to develop the other skills, knowledge, the eye for it, uh, and obviously the passion has to keep growing, and only then you learn, and one day become transplant stalwarts like the two gentlemen here. And we miss Anand sir. Anand sir, if he would have joined today, we would have learned even more of the life's work that Anand sir does. And like the already two stalwarts appreciating his journey through the transplant world. Well, thank you to Rajan sir. Thank you to Rahul sir for sharing your experience. I am sure every platform you go to after this webinar, there'll be so many youngsters coming to you and asking for your life experiences. That, but anyways, thank you so much, Rajan
थैंक
sir.
यू अक्षय. हम इतने बुढ़े नहीं है, हम भी यंग है.
Young ही है sir. Young ही है sir. But idea is that you have really worked hard to get something which is not very obvious, not very. It doesn't come naturally to every surgeon. It's learning vascular anastomosis is something which somebody might work hard and then probably achieve well. But
If
then
I tell
learning the
you, it is
transplant
easier
size.
than a bowel anastomosis.
Well,
I'll tell you, it is actually much easier than bowel anastomosis, because if it leaks on the table, you can repair it.
right, sir. So thank you again. Thank you, Rahul sir,
Welcome.
for your expert opinions. And I think Kolte sir is not joined right now. So I'll take this opportunity, if it's okay with the speaker and the chairperson, that we might sign off. sir.
Thank you so much. Thank you, Akshay,
Thank you so
for
much.
organizing everything. You are doing a great job for the society. I must congratulate you and the youngsters of your category who are taking up this tremendous job to increase the cohesiveness amongst the surgical community. You're doing a great job.
Thank you,
Thank you.
sir. Thank you so much.
And
Thank you,
Abhijit, thank you so much. And one last word. I mean,
sir.
Abhijit, along with USI and few other members, are bringing a structured program like we did, I mean, as a fellowship. And maybe in some time we are going to disclose it. So
Okay,
it's a structured program to learn all about transplants.
Amazing. That
that's
would be
great.
great,
That's
Rahul.
great.
So it's already in the
Congratulations. And
pipeline. So
whatever help you need from us, we are always there.
sure, sure.
Whatever
We'll
ways
be
we
needing,
can
and
contribute.
we'll be touching you soon.
Thank you so much. Thank you, Rahul.
Thank you, sir. Thank you again.
Bye.
Thank you
Bye.
to the audience for logging in. That's
Thank
all
you.
for today. Thanks a lot.